In this video, we shall discuss a few important points regarding your basic surgical skills. So first, let's discuss regarding your positioning on the operating table. Now, what is the importance of positioning on the operative table? It helps to facilitate your safe anesthesia and surgery. It reduces your adverse physiological insults. It optimizes your surgery exposure and your ergonomics, and the patient dignity by avoiding unnecessary exposure is maintained. The most common position is your supine position, and the various modifications of your supine position include your rose position. So what happens in your rose position? There is a slight neck extension for your head neck surgery. Then you have a Trendelenburg position, which is used for your pelvic procedure and in resuscitation of shock. So in Trendelenburg procedure, you have your knees slightly flexed and your head down. Then in your reverse Trendelenburg position, you can see that your head end is up and your foot end is down. Now this is often used in your gallbladder laparoscopic surgeries. Now next we have your preparation of the surgical site. The importance is to reduce your surgical site infection. Now it includes your removal of metals and any foreign bodies. Now hair removal. Where it should be performed? It should be performed at your operating room. When should it be performed? It should be performed after your prophylactic antibiotic is given to the patient. And how should it be performed? It should be performed with the help of your skin clippers with disposable blade. Now regarding the skin antisepsis, your World Health Organization recommends the use of chlorhexidine alcohol, but usually we have an alcohol based antiseptic that is to be used. And we drape the perimeter of the operative field using your sterile drapes. Now regarding your skin incision, now skin incisions are given with scalpel. So if you look, these are your various scalpel blade sizes and the shape. So we have this 22 blade which is used for your abdominal incision. So this is used for your abdominal incision. Then you have your blade 15, which is used for your minor surgical procedures. Then you have your blade 11, which is used for your arteriotomy. Then these blades are applied at right angles to the skin and not obliquely, because the shearing mechanism will lead to your necrosis. So the direction should be at the right angle to the skin and then extended at the desired direction. Now scalpels are always passed in your kidney dish. You never pass a scalpel hand to hand in your operating table. Now the various factors that are used in your skin incision are your Langer's line. Now these are your orientation of your dermal collagen fibers. However, the use of Langer lines have been considered controversial, and recently the relaxed skin tension lines are used to guide your skin incision, and you should avoid a skin incision on your bony structures. So this is a beautiful diagram again taken from your Bailey and Love, which shows your various skin incision. So you have your incision A, which is used in your sternotomy. Then you have your incision B, this periareolar incision, and then you have your inframammary incision. So these incisions are used in your breast surgeries. Then you have your subcostal incision. Now this is used in your open GB surgery. Then you have your paramedian incision. Now these are rarely used nowadays, but then with the help of a paramedian incision, you could go for operating a splenectomy or even a right hemicolectomy. Then you have your periumbilical incisions. Now this periumbilical incision is often used to make your first port in your laparoscopic surgeries. Then you have your edge, which is your McBurney incision. Now this McBurney incision is used in your appendectomy. Now we have your eye incision, that is your Fanistel incision, which is used in your gynecological procedures. Then we have your J, this is a Kocher's incision. Now this suture incision is used for your thyroidectomy. Then you have your clamshell thoracotomy incision, which is defined as a K. So this is your clamshell thoracotomy incision. Then you have your L. This is your chevron or a rooftop incision, which is often used for your Whipple's procedure. Then you have your midline incision. So this midline incision is used in your emergency laparotomy, and you have your inguinal incision, which is used in your repair of your inguinal hernia. Now you have the surgical exposure of the abdomen, which can be via an open surgical exposure, that is an intraperitoneal SS, which can be longitudinal, transverse, oblique or pelvic, or it could be a retroperitoneal SS in form of a flank incision, or a multi-compartment SS, that is a thoraco-abdominal incision. And via laparoscopic exposure, it could be a multi-port, single port, or a hand-assisted laparoscopy. Now regarding your abdominal incision, scalpel versus diathermy, it is seen that there is a lower requirement of a post-op analgesia with your diathermy. However, there has been no difference in your blood loss, surgical site infection, or your operative time. Now with respect to your transverse incision and your longitudinal incision, transverse incision are associated with less pain, less incisional hernia, and a better pulmonary function. So better pulmonary function. Now regarding your wound closure, so there are three types of wound healing that we can expect. One is a primary intention. These are the clean wounds that are often sutured together. Then you have your secondary intention, that is healthy granulation tissue filling up an open wound. Then we have a tertiary intention, which is your delayed closure or skin grafting. Now regarding your sutures that are used, so the basic characteristics or the desired characteristics of a suture material, it should be easy to handle, predictable behavior in tissues, predictable tensile strength, sterile, glide through tissues easily, secure knotting ability, inexpensive, minimal tissue reaction, non-capillary, non-allergic, and non-carcinogenic. Now on the basis of your physical structure, the monofilament sutures are those which are smooth, tend to slide, and are difficult to knot. On the other hand, you have your multifilament or braided suture, which are easier to knot, but they have a surface area of approximately around 1000 times more, as a result of which the capillary action because of the capillary action it interstices and causes the bacteria to lodge. Now the strength, it depends upon your constituent material, thickness, and your response to the tissue. Now absorbable sutures usually decay of strength with time. In case of a non-absorbable, like in synthetic or polypropylene, they retain their strength, whereas a biological non-absorbable would lose strength with time. So a few important points regarding which suture has to be used. In case of a vascular anastomosis, you have a smooth non-absorbable non-elastic suture. In biliary anastomosis, you use an absorbable suture, and in case of a bowel anastomosis, you would use a polygalactoline PDS or a polypropylene, which usually varies from surgeon to surgeon choice. Now regarding the needles, so these are your various types of needles that are used. So this is your 1/4 of a circle, this is your 3/8 of a circle, half of a circle, 5/8 of a circle, half curve, J needle, a compound curve, right. So please remember this needle shape, as they can just simply ask you an image based question on the basis of this needles. Now regarding your various suture techniques, so the various suture techniques, you can get an image based diagram trying to identify. So you can see the first suture technique, this is your interrupted suture technique. Then you have your mattress suture technique, which can be your horizontal or a vertical mattress suture technique. Then we have your continuous suture technique and your subcuticular suture technique. So you can expect an image based question asking you to identify your type of suture technique. Now regarding your knots, I have shared the image from a net, which the most important knots that are asked to you, which are your square knots, granny knot, and your surgeon knot. The main confusion that occurs is usually between your square knot and square knot and your granny knot. So if you look at the throw of the knot, so if you look over here at the down, so this is going this way, and similarly over here. Now in case of granny knot, they both are in the same direction, whereas in case of a square knot, they are in different direction. So this is what is able to help you to differentiate between a square knot and a granny knot. So this is one of the most common questions and the most confused topic that is asked from the knots with respect to your square knot and your granny knot. Now regarding your abdominal wall closure, it could be either a lead closure or a mask closure or a continuous closure versus an interrupted closure. Now it is found that your continuous closure is better because it maintains your uniform tension, in contrast to your interrupted sutures where your uniform tension is not maintained. The suture that is used is your PDS, which is a delayed absorbable monofilament material, and the distance between sutures initially was considered to be 1 centimeter, but nowadays it is recommended to have your suture distance 0.5 centimeter. Now regarding your hemostatic mechanisms that are used intraoperatively, it can be divided as mechanical, which includes your digital pressure, ligatures, hemostatic clamps, vascular stapling devices, wound packing, bone wax, and image guided embolization, or thermal, which could be electrosurgery, cryosurgery, argon beam coagulation, and your vessel sealing device, and your chemical or your topical hemostatic agents in form of your physical or biological. Physical agents like your absorbable collagen, gelatin, oxidized cellulose, and biological like topical thrombin, fibrin sealant, and your tranexamic acid. Now a few important points regarding your electrosurgery. So I have just shared this table from your Bailey and Love, which I think would be sufficient for you guys to know in your electrosurgery. Now cutting, it includes your lower voltage current and a higher voltage cutting would include a lower voltage current, whereas coagulation includes a high voltage current. It is continuous in case of cutting and interrupted in case of coagulation. Energy is concentrated over a small area in cutting, whereas energy is dispersed over a large area in coagulation. Now tissue is heated rapidly to a higher temperature, causing your vaporization of tissue and thereby resulting in cutting tissue, whereas the modulated current allows the tissue to cool slightly, so the tissue heating is lower than with the cutting mode, and this causes a dehydration effect, that is the loss of cellular fluid and your protein denaturation, resulting in your coagulation of tissue. Dehydration is not as effective as vaporization of the cutting tissue, but is ideal for hemostasis. Now bleeding is stopped by the combination of your distortion of walls of blood vessel, coagulation of plasma proteins, and stimulation of your clotting cascade. So there is a minimal lateral spread and collateral damage in your cutting current, whereas there is an extensive lateral spread in your coagulation. Now cutting divides tissue by generating sparks which are to tissue, that is the most efficient when the tip is held just above the tissue, whereas in similar to cutting in coagulation, it is similar to cutting and it works best when held just above the tissue with no contact or minimal contact with the tissue. Now the uses include to clean cut off tissue and to be used to dissect or divide tissue and not just to make skin incision. Now uses of coagulation is for coagulation and achieving hemostasis. So these are your few important points which have a lot of potential MCQs to be framed from your electrosurgery. Now moving down to your drains. So these are your various types of drain. You can see over here, this is the corrugated drain system, corrugated rubber drain. Then you have your image B, which is your closed suction system, and then it is a closed non-suction drain, right, and this is your closed suction drain. Now regarding your drains, what is the current role of drain in your non-GI surgery? Now it is said to avoid routine drain placement in thyroid surgery, breast lumpectomy, inguinal hernia repair, and to consider your routine drain placement in radical or modified radical neck dissection, parotid surgery, axillary dissection with or without mastectomy, inguinal lymphadenectomy, and your ventral hernia repair in obese patient. And The current role of drain placement in your GI surgery is said to avoid routine drain placement following colonic surgery, small bowel resection, hepatic resection and cholecystectomy, and to consider routine drain placement following your esophageal surgery and major pancreatic resection, and the selective use of drains in your rectal surgery and gastric resections. So this is all about your surgical skills, the basic surgical skills, the few important topics which are asked in your exam as your one-liners, or it could come as a clinical based scenario testing your knowledge regarding the basic surgical skills. Thank you.